I'd like to thank the Society of Academic Emergency Medicine for allowing us to present our research on the onset to needle time of less than or equal to 90 minutes may not improve short-term outcome in patients with acute ischemic stroke. My name is Greg Guerra, and I'd like to thank my co-authors, Shona Elliott, Sanjay Gupta, and William Abduback for their participation in this project. The American Heart Association's Target Stroke Phase 3 goal is to achieve door-to-needle times within 45 minutes in 75% or more of acute ischemic stroke patients treated with IV TPA. Studies have shown that early administration of TPA in acute ischemic stroke is associated with reduced mortality by the time of hospital discharge and better functional outcomes at 3 months. However, most door-to-needle outcome studies fail to consider the last known well beyond TPA exclusion criteria, and few studies focus on stroke onset or last known well to the needle time. The objective of our study was to examine whether an OTN or onset to needle time of less than or equal to 90 minutes for acute ischemic stroke is associated with improved short-term outcomes. Our study was a single-center retrospective cohort that was performed in a suburban tertiary care thrombectomy-capable hospital with 75,000 ED visits annually. The participants in this study included patients treated for acute ischemic stroke with TPA within 4.5 hours from last known well between January 1st, 2020 and November 30th, 2020. The exposure that we studied was the onset to needle time of less than 90 minutes, and the outcomes that we looked at were modified Rankin score of 0 to 1 at hospital discharge, a discharge disposition to home, and a combined discharge disposition to home with a modified Rankin scale of 0 to 1, essentially patients who are being discharged home with very little to no deficits whatsoever. And the measures that we looked at were crude odds ratios with 95% confidence intervals. There were 75 patients in our cohort that were treated with TPA within 4.5 hours from onset of symptoms. The median age of the overall group was 62 years, with 49% being male. The median last known well to arrival time was approximately 64 minutes, with an interquartile range of 32 to 117 minutes. And the median door-to-needle time was 41 minutes, with an interquartile range of 32 to 55 minutes. And within that group, what we found was that there were 14 patients that were treated in under 30 minutes with IV TPA, 31 treated with between 30 and 44 minutes, 17 that were treated between 45 and 59 minutes, and 13 that were treated with TPA in greater than 60 minutes. We had no cases of post-TPA intracranial hemorrhage. The table that is shown on this slide demonstrates the difference between the groups as split out by onset to needle time of less than 90 or greater than 90. There were 27 patients in the less than 90 onset to needle time group and 48 in the greater than 90 group. And there was no statistically significant difference in age, gender, or NIH scale between those groups. For the outcomes that we're interested in, we found overall no statistically significant difference between these two groups. Patients who had an onset to needle time of less than or equal to 90 minutes had a slightly higher proportion of discharge with an MRS of 0 to 1 as compared to the onset to needle times of greater than 90 minutes. However, patients with an onset to needle time of greater than 90 minutes in our study had a slightly higher proportion of being discharged to home or being discharged to home with a modified Rankin scale of 0 to 1 as compared to the onset to needle time of less than 90 minutes. And none of these findings were statistically significant. Limitations. This is a small sample size in a single hospital setting, which of course introduces bias to the results. There are multiple confounders that may limit hospital discharge following an acute ischemic stroke. Concomitant medical issues such as active diabetes, active hypertension certainly could limit discharge. Social issues are a known issue for discharge from the hospital. And certainly there may be social issues that prevent a patient from going home when they should be able to go home, even after a stroke. Obviously, the individual components of a stroke examination aren't necessarily equal. And although there was no statistically significant difference between the groups in our study, an NIH stroke scale of 7 might be clinically much different than an NIH stroke scale of 5. And we did not look at pre-stroke modified Rankin scales before the onset of symptoms, which can also limit our results. In conclusion, among patients with acute ischemic stroke treated with TPA, shortened onset to needle time did not provide a more favorable short-term outcome. Thank you very much.
Hi, my name is Lauren Mamer, and I'm going to present my lightning oral abstract today entitled Changing Use of Advanced Neuroimaging in the Emergency Department Across the Mechanical Thrombectomy Era. I don't have any financial disclosures. As we all know, neurologic concerns are a frequent cause of presentation to the emergency department. Evaluation of these complaints requires assessment for serious causes of neurologic symptoms, including acute ischemic stroke. In the case of acute stroke, the role of imaging in this evaluation has changed dramatically over recent years. Use of cross-sectional imaging in patients with suspected stroke has become more complex as the window for intervention on stroke patients has expanded with the advent of mechanical thrombectomy. The studies establishing these longer intervals for potential intervention did so by using both physical exam and imaging criteria to select appropriate patients. With this increase in indications for advanced CT imaging, in particular CTA and CT perfusion, it makes sense that the rate of use of this imaging in emergency departments would have increased, although it is not yet known if this change was actually observed, as there are no currently published estimates in the literature. We hypothesized that CTA and CT perfusion imaging in the emergency department has increased across the mechanical thrombectomy era. To address this question, we used the National Emergency Department Sample, the NEDS, which is a healthcare cost and utilization project database, to obtain national estimates of CTA, CT perfusion, MRI, and non-contrast head CT use from 2013 to 2018 using their CPT codes. Inclusion criteria for our study included patients at least 18 years of age, emergency department encounters in which the patient was not admitted to the same hospital so that we could preserve the CPT coding, and ED encounters occurring between 2013 and 2018. What you can see here is that there has been a dramatic increase in the rate of CT perfusion and CTA acquisition from 2013 to 2018. It is displayed here as a rate per 100,000 ED visits with 95% confidence interval. It's clear from these trends that emergency departments are using more advanced imaging over the time period studied, particularly in relation to CTA and CT perfusion. In parallel, on the bottom of this slide, you can see the dates of publications supporting CTA and CTP selection of patients for acute stroke intervention along the bottom. One observation that could be made is that, in general, anecdotally at least, trends towards imaging acquisition in the emergency department are that we are imaging people more, and perhaps this is just a reflection of an overall trend towards more imaging. Interestingly, the use of MRI and non-contrast head CT have increased, but more modestly, suggesting that this dramatic increase that we saw in the previous slide is not really just part of a change in overall imaging and how we use it in the ER. Again, rates are expressed in a rate of imaging modality per 100,000 ED visits with 95% confidence interval. Because advanced imaging acquisition depends on both patient and hospital factors, we wanted to look closer at the demographics of hospitals specifically acquiring this imaging over the time period. We were most interested in these changes over CTA and CT perfusion imaging that had the most dramatic changes, but as CT perfusion imaging is still pretty infrequent, CTA was chosen as the area of focus. For this analysis, we looked at the rate of CTA acquisition for each hospital in the dataset. There are approximately 950 hospitals each year in the dataset, and this is a representative sample of the over 4,500 hospitals you see in each year on the slide. As you can see, both the median rate of acquisition of CTA and the spread underwent dramatic changes over the time period that was studied. We then wanted to look closer at some specific hospital properties that one might expect to vary with CTA use. In this slide, you can see our evaluation of hospital CTA rate based on whether the hospital is a teaching hospital or not, and whether or not it is privately or publicly owned. As you can see, the median CTA rate is higher in teaching hospitals than in their non-teaching counterparts in both the first and last years of our dataset. When combined with the patient-level data, approximately 60% of CTAs in the dataset occurred at teaching hospitals in 2013 and approximately 69% in 2018. Private hospitals tend to have higher rates of CTA acquisition than their public counterparts, and both groups show a trend towards an increase from 2013 to 2018. The urban and rural location of a hospital also affects the ability of that hospital to participate in networks of stroke care, which might change its rate of imaging acquisition. Here, we combine several NEDS categories to include metropolitan designated locations and non-metropolitan locations. We can see a trend towards increasing CTA use across both metropolitan and non-metropolitan hospitals. Interestingly, the trend towards an increase in CTA rate in 2018 spans a broad range of hospital volume, suggesting that this effect is not driven by a few high-volume centers with very liberal CTA policies. The next step in our analysis will be to divide hospitals into high and low groups according to their CTA utilization rate. Here we evaluated hospitals in the top 1/3 of CTA use and hospitals in the bottom 2/3 of CTA use, and have displayed the features of high utilizers in 2013 and 2018. As you can see, the hospitals in the high utilizer group represent a broad geographic distribution. A majority of them are in metropolitan locations and only a small minority are public. In conclusion, the use of CTA and CT perfusion imaging is accelerating and increasing at a rate that is not accounted for by a general increase in imaging use overall. This trend has been observed across multiple hospital features, including teaching status, metropolitan location, and public ownership, and the trend is not confined to a single demographic feature. Further directions of this project will include patient-level demographic data as well as further inspection of the CTA high and low utilizing groups. I would like to acknowledge the Resident Research Development Grant from the Department of Emergency Medicine at University of Michigan for supporting this project. Here are my references, and thank you so much for your time and attention.
Hi, this is Loretta Matheson from Stanford University, and I'm going to talk to you about determining historic progression of stroke center certification. And that requires using technical sleuthing and time travel. As part of a larger research project at Stanford, looking at stroke centers, we wanted to do a simple thing, which is just figure out for each of the hospitals in our study, was it stroke certified or not for each of these years from 2006 to 2014. Now, what I knew is that there are three main certification bodies: Joint Commission, DNV, HFAP, and each of those provides pretty nice, current lists of stroke certified hospitals online. I knew that several states did their own also, but I knew that the three big certification bodies, what they provided online was pretty good. What I learned is that there is an ischemic block in access to historical stroke center data, historical being the key word. The first big blockage is that these certifying bodies won't provide historic information. Even if you university name drop, say it's for research, ask nicely. And they point to some historic data being online, but you have to hunt and peck and find it, and then it's not current. Okay, so more on this to come. Blockage number two is the more commonly maybe understood problem, in that hospitals change names, they're grouped in different ways, they move locations. The key problem here is that the certifying bodies, these stroke center certifying bodies, don't provide any interlinking IDs for hospitals, like Medicare ID, or the AHA ID, or the Universal Hospital ID. So you kind of have to, try to follow a hospital over time. More on this. Okay, so what does a researcher do, a stroke researcher do? To find the historical lists of certified hospitals, you need to time travel. So if you could just go back in time and go to those the websites that like the Joint Commission offers, if you could go back to 2006 and get that information, and 7 and 8 and 9, that'd be great. And thankfully, the group, the Internet Archive, which is a nonprofit group, had the wonderful foresight to capture web pages. So starting in about 1996, they started capturing web pages, and they've captured about 500 billion so far. And it's kind of like magic. Now, using their Wayback Machine, you can access those pages. It's not like we access things today exactly, so there's no Google searching for keywords on a page. You can only search for words within a URL, not a web page. But still, it's kind of like magic. You can get to that information. For the second part, about connecting the same hospital over time, given that there are no identifying hospital keys to go with, well, this comes down to kind of brute force technical sleuthing. You just need to write some algorithms to match maybe what you hope will be the consistent part of the hospital name. And the state, that usually stays the same, but things like city, zip, those change. And so you have to kind of do some clever matching to see, I think it's the same hospital, let's try this. And then of course, using the web to compare the different locations. Sometimes it's the same location, it just changed, the street name changed. And there are articles out there about like, oh, this hospital is closing and it's reopening as, that kind of thing. So that can help to provide that link through time. Okay, the long term. What is the long-term treatment for the blockages to the historical stroke center data? I think the first thing, maybe the only thing we can do, is reach out to those certifying bodies and help them understand the ways in which, by not providing the historical data, they're preventing, or at least providing huge hurdles to effective stroke center data and the research that we need to do on that. And then we need to just demand change, because this information doesn't need to be so difficult to access. If you have questions, let me know.
Hi everyone, my name is Philip Wang and I'm a second-year medical student at the Cleveland Clinic Northern College of Medicine. Today I'm really excited to be able to share some research our group did this past summer looking at trends in the pharmacologic management of migraine headache in the ED. We have no disclosures and there was no funding provided for this study. As a bit of a background, headache is the fourth most common chief complaint in the ED and makes up around 3.1% of all visits. One of the most common causes of primary headache are migraines, which lead to 1.2 million ED visits per year. There are several recommended treatments to treat migraine, and these include dopamine antagonists, antiemetics, and NSAIDs, which have both been shown to induce migraine relief with minimal risk. Friedman and al. Have previously described the frequencies of medication use in the ED management of headaches in 2010, and we wanted to provide an update on that data. So our objectives were to describe changes in the pharmacologic management of headache between 2010 and 2015 to 2017. To do this, we used the National Hospital Ambulatory Medical Care Survey, or the NHAMCS, and this is a multi-stage national probability survey that samples ED visits. It does this by first sampling 112 geographic primary sampling units, which are just counties or groups of counties, sampling hospitals within each primary sampling unit, and then sampling ED visits within the hospital. Then, weighting of visits is done to produce nationally representative data. As far as what we did is we analyzed visits from both the 2010 and the 2015 and 2017 NHAMCS datasets with any discharge diagnosis of migraine. We analyzed medications administered and then also patient characteristics for these visits. Then we used Rao-Scott chi-square test to analyze drug prescription frequencies and compare them. So looking at the patient demographics of our cohort, we sampled 561 visits from 2015 to 2017, which led to a weighted count of 3.9 million visits. Consistent with prior studies in the literature, our patient population was mostly female, young between the ages of 19 and 50, white patients presenting with 8 to 10 or severe pain, and private insurance. The most commonly prescribed medications were antiemetics, NSAIDs, and diphenhydramine. Dopamine antiemetics and NSAIDs are both guideline-recommended agents, and we believe that diphenhydramines increased use is due to administration to prevent akathisia side effects from dopamine antiemetics, and we do not think clinicians are electing to use it more in the primary management of migraine. IV opioids are prescribed in 27% of visits, and opioid analgesics are administered in 13% of visits, which is down from 2010. I'll be talking about these data a little bit more in about 10 minutes in my upcoming presentation. Getting to the real meat of our study, we can see that IV opioids and opioid analgesics as a class were prescribed significantly less, with most of the individual drugs prescribed less as well. I'll go more into details of the factors behind IV opioid administration and the timeline trend more, and also in my upcoming presentation. NSAIDs as a class were also prescribed more, with clinicians electing to use ketorolac and ibuprofen both more. Antiemetics as a class were actually not prescribed more, but the breakdown is far more interesting. The most common antiemetic was actually the anti-serotonergic ondansetron, which is not recommended as a first-line treatment in the management of migraine. We believe instead that it was used to prevent nausea associated with migraines. Metoclopramide was the antidopaminergic agent that was used more often in 2015 to 2017 than in 2010. We saw a decrease in the use of promethazine, most likely attributable to its black box warning given in 2009 due to tissue injury with IV administration. We also saw an increase in the use of acetaminophen and diphenhydramine, but no increase in the use of triptans in the ED setting, even though they are considered first line in the outpatient setting. We believe that ED clinicians may be electing against using them because of fears of coronary vasoconstriction and side effects. As far as the limitations of our study go, the NHAMCS is a large national probability-based sample set, and thus is vulnerable to bias or poor abstraction. Therefore, our studies must be verified using non-weighted multi-center studies. Furthermore, our inclusion criteria of ICD-9 or ICD-10 diagnosis of migraine undoubtedly failed to include many migraine patients who receive non-specific diagnoses, such as just headache, as migraine is commonly underdiagnosed in the ED. We chose to maximize specificity for migraine patients rather than include all headache patients. This approach best captures how ED clinicians are managing patients who they suspect have migraine, which was the ultimate goal of our study. The key takeaways of our study is that the administration of opioids and opioid analgesics and ED migraine management fell from 2010 to 2015 until 2017, and then also that first-line guideline recommended agents such as NSAIDs and metoclopramide were used more in 2015 and in 2017 than in 2010. Thank you for your time, and I really appreciate your attention.
Hello, and thank you for joining me to present this abstract, The Impact of New Advanced Imaging Requirements on TPA Administration. My name is William Afterback. The co-authors for this study are Greg Gara and Sanjay Gupta. We have no conflicts of interest to report. With regard to the background, stroke care has been evolving, and use of advanced imaging modalities like CT angiography and CT perfusion has become more commonplace. And as these additional requirements become more commonplace, we have to expect that there may be time requirements and time delays associated with them. There may be other technical aspects like inserting an IV prior to attaining those image modalities, and these may affect the time in which a patient receives TPA. The goal, of course, is to actually have better accuracy in determining which patients should ultimately receive TPA to begin with. The objectives of the study had two aims. The first was to determine whether or not the use of advanced imaging had an impact on whether or not patients receive TPA. The second aim was controlling for other variables whether or not receiving advanced imaging caused any delay in door-to-needle time in patients receiving TPA. This was a retrospective analysis of a quality database of all patients treated along the acute stroke pathway. The study site is a stroke center. The variables that we examined included the use of advanced imaging, door to TPA time, arrival via EMS, time of arrival, that was in day versus night, and duration of symptoms in minutes. For analysis, the first phase of the study, binomial logistic regression was performed to determine the impact of AI on receiving TPA. And then a regression was run to determine if there was a difference in door-to-needle time between patients that had received AI versus those that have not, when controlling for arrival via EMS, the time of arrival, and the duration of symptoms. So with regard to our results, our total sample was 306. Within that sample, 119 patients received advanced imaging, 187 did not receive advanced imaging, 44 received TPA, and 262 did not receive TPA. With regard to our TPA population, 16 had advanced imaging and received TPA, and 28 did not have advanced imaging and did receive TPA. With regard to our results, we found no significant difference in either of our aims, meaning the performance of AI on patients did not cause a statistically significant impact on likelihood to receive TPA. We also did not find that patients that received AI had any longer period of door-to-needle time. So for this study, we found that it's important to review and examine the impact of new aspects, modalities of care, especially in the treatment of patients presenting with stroke, and how those new criteria, modalities, imaging techniques may impact things like door-to-needle time. We found no significant difference in both of our aims, meaning the use of AI did not have any significant difference at our site on whether or not a patient received TPA, nor did the use of AI delay in any way the door-to-needle time for patients receiving TPA. The study does have some significant limitations. It is a relatively small sample size, and it is retrospective in nature. Going forward, we are going to do prospective examination of essentially the same criteria with a couple of other clinical factors that may be predictive of care for patients presenting with acute stroke. I thank you for your time today, and I'll pause and see if anyone has any questions.
Hi everyone, my name is Philip Wang, and I'm really excited to be able to share some research our team did entitled National Trends in the Management of Migraine Headache with Parenteral Opioids in the ED from 2010 to 2017. I apologize if people were here from my previous presentation get a sense of deja vu, as this study levies the same dataset and uses a very similar methodology as the previous one. However, we did do a slightly different analysis, and it provides a more focused look, just analyzing who is getting opioids for migraines in the ED. We have no disclosures, and there was no funding provided for this study. Headache is the fourth most common chief complaint in the ED and makes up around 3.1% of all visits. One of the most common causes of headache is migraine, which leads to 1.2 million ED visits per year and thus represents a great burden on EDs. There are several recommended treatments to manage migraine in the ED, and these include dopamine antagonists, antiemetics, and NSAIDs, and these have all been shown to be fairly efficacious. Opioids are also occasionally used to treat migraines in the ED. However, they're relatively contraindicated because they've been shown to lead to longer stays, increased recidivism, and decreased sensitivity to more effective migraine treatments. A study published by Freeman et al. In 2015 found that IV opioids were administered in 49% of migraine ED visits in 2010. We were surprised to see this high number given that they're contraindicated, so we wanted to see if there was any change in opioid prescribing practices since then. The objectives of our study was to evaluate frequency of opioid use in the ED management of migraine since 2010 and provide an update on that, and also to identify factors associated with opioid administration in the ED migraine management to see if we can identify patients who are more at risk for receiving opioids. To do this, we levied the National Hospital Ambulatory Medical Care Survey, which is a multi-stage national probability survey that samples ED visits. To do this, it first samples 112 geographic primary sampling units across the United States, and then from each primary sampling unit, they sample hospitals, and then from each hospital, they sample individual visits. Thus, the individual visit is the observational unit of the NHAMCS. Then they do weighting of visits to produce nationally representative data. We analyzed visits from the 2010 to 2017 NHAMCS datasets with any discharge diagnosis of migraine. We analyzed the medications administered and also the patient characteristics for these visits. As far as what we considered an opioid, we consider medications in the multum drug category 060. And these are the narcotic analgesics and include drugs such as hydromorphone, nalbuphine, and morphine. Importantly, this does not include oral analgesic combinations like hydrocodone and oxycodone. Then, we use multivariable logistic regression analysis to determine the factors associated with opioid administration. Looking at our cohort from 2010 to 2017, it consisted of 1,846 individual visits, which led to a weighted count of around 9.6 million visits. As expected, our patient population was mostly white, female, and middle-aged, presenting with severe pain. We saw that the use of IV opioids for migraines fell in a fairly linear fashion from 2010 to 2017. In 2010, they were administered in 49% of all visits, but by 2017, they were administered in 28% of visits, representing an almost 50% reduction in IV opioid use for migraines. This significant decrease in opioid administration is much more aligned with guidelines for migraine management, and we hypothesize that this decrease is due to several factors. First, it may be due to prescription drug monitoring programs. Also, it could be due to increasing public awareness of the opioid epidemic, and finally, it could be due to a delay in guidelines being published and the physician awareness and adherence to those guidelines. We use multivariable logistic regression to identify several factors associated with opioid administration. We found that women had a 1.5 times greater odds of being administered opioids. The literature has shown that women have higher rates of prescription opioid use and are more likely to fill opioid prescriptions. Thus, we hypothesize that the medication history may be influencing physicians and providers' prescribing practices. As far as age goes, we were surprised to find the finding that older patients are more likely to receive IV opioids in the management of migraine, as this was inconsistent with the literature. The literature indicates that older patients are actually less likely to receive IV opioids for migraine due to the risk of falls, and thus opioids are generally contraindicated with Beer's criteria in elderly patients. We hypothesize that physicians may be expecting other secondary causes of headache in elderly patients, and thus be electing to use opioids to manage initial pain before a diagnosis is made. Previous studies demonstrated that office-based visits for migraine had no racial discrepancies in opioid prescribing practices, but we identified that white patients were more likely to receive opioids than black patients. This is a novel finding and requires future verification in future studies. Finally, we were not surprised to see that patients who were presenting with more severe pain and who were on Medicare or private insurance were more likely to have their pain controlled than patients presenting with milder pain and Medicaid patients, unfortunately. As far as key takeaways go, we found that opioid administration and ED migraine management fell from 2010 to 2017, but should be further reduced. We also identified several factors associated with greater odds of opioid administration, and these included female sex, older age, and white race. Future work should aim to corroborate these findings in multi-center studies using datasets that are not probability weighted. Thanks so much for your attention, and I really appreciate it.